Yeah, so I think first off, there's widespread agreement that adults age 50 to 75 should undergo regular colorectal cancer screening. There's some discussion about the frequency of screening and the type of test to be used. Where we may differ slightly from other clinical practice guidelines on whether to begin screening at age 45 or begin screening at age 50. That's what we talked about today. ACP believes and looks at the evidence and says that the best balance of benefits and harms is really beginning screening at age 50, and that clinicians should consider recommending against not screening at age 45 because it would be a better benefit by allocating resources and screening decisions to those at greatest risk and their greatest certainty. And that's been widely touted, and there very well may be a very small increase. Colorectal cancer is extremely rare in individuals under the age of 50, okay? And the recommendation by many has been based on really two aspects. One is the change in the incidence. Over the past 10 years, that has gone up by about 6 per 100,000, or 1 per 16,000. Perhaps on a national basis, it might be a little larger. But for any individual that I'm talking with in my clinic, I have to say, last year we were recommending 50. Now, because your risk is maybe 1 per 16,000 higher, what would you think? Most of my patients would say, no thanks. And I can say, we can get very similar, if even greater benefits at 50 with fewer harms. Let's recommend screening now. Consider not screening. Most of my patients will say, that sounds good to me. Others might say, I'd like to be screened, which would also be fine. And the other reason why they have made those recommendations based on what we call modeling studies, statistical models, kind of the way we predict the weather. And if you believe that we can predict the weather 3 or 5 days from now and how reliable we are, think about these models are trying to predict a full life event. And based on those models, which are highly optimistic, they assume 100% adherence. They assume progression to develop cancer about twofold higher than we really see in clinical practice, and other aspects that are much, much higher than we see in clinical practice. Even there, if you screen people beginning at age 45 compared to 50, they'll get about an additional 5 days of life gained in their entire lifetime. Yet they have to undergo some of the harms, burden, and costs. ACP believes we could do better, reduce disparities, improve equity, reduce colon cancer incidence and death by focusing those resources on individuals where there's greater certainty of benefit and those who need it who have not been getting screened, those between the age of 50 and 75. These conversations often revolve around not only when to start, but when to stop. And like with all healthcare decisions, we go through phases in life where certain medical procedures, tests, and treatments might be more effective and have a better balance of benefits and harms at certain phases of life or in certain conditions. Same with colon cancer screening. We recommend beginning at age 50. There may be some variability in the type of test or the frequency, which is highly dependent on patients' preferences and values. But then I also have a conversation about as we get older, and if you've been compliant with screening all along, your risk of developing cancer, your risk of benefiting from this treatment decrease, but the harms begin to increase. So with like many decisions in life, I recommend we focus on some other things. And fortunately, the good news is we can decrease some of the intensity of healthcare and improve your life by maybe not screening at this point. And most of my patients are very, very comfortable with it. That they may be a little less comfortable because it has the word cancer behind it. And for many, especially in the United States, that has a big emotional toll. I try and talk to them about that and say for many, cancer could be a very, very bad prognosis and condition, and you may have family members. But for others, I'll say it's not too dissimilar to many other health conditions, such as heart disease, lung disease, etc. And how would you think about maybe treating yourself with a cholesterol for heart disease? I might say, I don't want that pill. I say, well, that pill might give you a benefit about 100-fold higher than continuing screening. Let's see about where we can focus on things most likely to be helpful for you and that meets your preferences and values.